Sir, I'll present a case of 80-year-old male patient who is a resident of Noida. He is a retired civil servant. Sir, I'm audible?
Yes, you are.
Yes. Sir, a retired civil servant. He is a father of two children, Hindu by religion and history given by himself, and a son-in-law, which is reliable. Sir, a patient presented with a complaint of decreased appetite, nausea, shortness of breath since last 7 days. Hello?
Yes.
bolo.
Hello?
Bolo. We can hear you.
Yes, sir. So, patient presented with a complaint of decreased appetite since last decreased appetite, nausea, and shortness of breath since last 7 days. Complaint of bilateral fetal edema and decreased urine output since 10 days. And he has a rash all over his body, which was more on upper limb and lower limb since last 6 months.
Last 6 months. Okay.
Yes, sir.
Right. So this is the presenting complaint, is it?
Yes, sir. Yes.
Okay. So tell me, with these three presenting complaints, a rash which is going on for 6 months,
Sir.
and a short history, 10 days of fetal edema, fall in urine volume.
Yes, sir.
And nausea, signs of fluid overload. What do you think is the likely diagnosis going to be? You put it in the broad syndromic diagnosis.
Sir, with fetal edema, shortness of breath, rash and all. So with rash, it's on 6 months going. So presentation may be a small vessel vasculitis, but with a short history of decreased appetite, nausea, shortness of breath is since 10 days. So it may be some RPRF. RPGN kind of person.
Why RPGN? With this presenting history, you can't be sure whether this is glomerulonephritis alone.
Yes, sir.
And how do you know this is acute there? Huh?
So,
we are not analyzing the history yet. We are analyzing only presenting complaint.
Yes, sir.
Okay. So
yes,
either you say that the rash. So if this rash, maybe are you trying to say this rash is unrelated to the disease?
Sir, that's we have to. So by history, its rash is related to rash.
Complaint, where would you put these two things? One, we are clear that he's probably having some acute kidney injury.
Yes, sir. Yes, sir.
Okay, and this rash. So tell me some diseases you know who will have a rash appearing first, and then 6 months down the line you will have AKI.
Sir, small vessel vasculitis like ANCA associated vasculitis, and another one is a cryoglobulin. Hello, sir.
Yes, go ahead.
Cryoglobulin vasculitis.
Okay, what sort of a rash do you have in cryoglobulin?
Sir, in cryoglobulin vasculitis, rash is mostly hello, sir. Purpuric rashes are there, which was associated with the lesion which ulcerated.
Yeah, and where are they? Mostly in the periphery.
Mostly in the periphery, in the lower limbs, and so maybe sometimes on buttocks.
Yes. So why are you thinking this can be cryoglobulin? What else? Tell me some other rashes. Your distribution of rash, you said, was on the limbs and in the body, on the body, no?
Sir, rashes are mostly on the limbs.
Limbs, right.
Face, palm, they face, and torso.
Yeah. So tell me some rashes which will appear like this, and there the patient will have RPGN, as you say, vasculitis.
Sir, with acute rash and rash
with rash to 6 months se chal raha na beta.
Yes, sir. Sir, vasculitis, ANCA associated vasculitis.
What type of rash does ANCA?
Purpuric rashes which occurs in crops and which heals by scab formation.
Right. Okay. You must have seen a host of ANCA associated vasculitis, no?
You must have seen some patients.
Have you seen a rash in them?
Sir, mostly they don't
have. Yeah. What are the vasculitis? So, you think in those lines, what are the vasculitis which are definitely associated with a rash? So you tell them first.
Sir,
No?
IgA hello.
So IgA, very good. So he may be IgA for 1 year, and now he has developed a crescentic transformation.
Sir, sorry to say, sir, but patient's age-wise is a 80-year-old male
That's
patient.
all right. We are just discussing your presenting complaints.
Yes, sir. Yes.
No? Achha, what
Yes,
are the
sir.
other vasculitis which have a rash? What is the? Achha, let me ask you directly. What is the rash seen in lupus nephritis?
Sir, lupus
SLE?
nephritis rashes are present. Is most
No,
malar rash.
Malar rash.
Malar
Bas
rash.
khatam ho gayi baat. That is all. The examiner wants to know whether you know the lingua,
Yes, sir.
whether you know the language that is associated. What
Yes,
is the
sir.
rash you have in scleroderma?
Sir, scleroderma. Sir, scleroderma rash is a salt paper appearance kind of rash is there.
Where is it? What is a heliotrope rash?
Sir, heliotropic rash is around the, it's present around the eyes, and it is a presentation of amyloidosis.
Oh, is it? Okay, right. So you go back and check this. Okay. Acha. ठीक है. Now we think that this chap is, so you should analyze in those. That is how you'll ask questions, right? So
Yes,
now
sir.
tell me, is AKI a common problem in elderly? 80 years old?
Yeah, sir.
Yes
sir.
or no? Yes.
Yes, sir.
Okay, now tell me why. And what are the
Sir,
common causes of AKI in the elderly?
Sir, elderly patient, they have comorbidities like diabetes, hypertension, heart diseases. So, decrease renal residual function.
Very good, excellent. So they are more prone to what type of injuries?
Sir, they are present volume hypovolume.
No, what type of renal injury?
Sir, ATN.
ATN. So ATN is the commonest reason. And what are the common causes of ATN in the elderly?
Sir, ATN are drug induced and sepsis, septic,
which drug?
septis. Sir,
finish the drug part. Which drug?
Sir, nephrotoxic drugs such as aminoglycoside, amphotericin, and NSAIDs.
Yes, NSAIDs are very type of the elderly.
Hello. Hello. Hello.
Is it me?
Hello.
Yes.
Sir, your voice.
हाँ, तुम्हारा freeze हो गया था, प्रेम.
Sir.
Okay. So NSAIDs are common because they are prescribed commonly in the elderly for backache and osteoarthritis.
Yes, sir.
Then which other drug? Aminoglycosides.
Aminoglycosides, sir. Amphotericins.
Amphotericin भी कहाँ देते हैं यार? तुम बताओ तुमने
No,
अपनी
sir.
nephrology
Aminoglycosides.
हाँ. And the other ACE inhibitors and ARB.
Yes, sir. ACE-ARBs, protease pump inhibitors.
They are commonly given for congestive heart failure that the elderly will have.
Yes, sir.
Okay. Because when you write a topic, elderly with RPGN, everybody knows what we are going to discuss. So it's a good occasion to discuss the elderly, right?
Yes, sir.
Otherwise, elderly AKI discussing. So you think ATN is the commonest cause of AKI in the elderly?
Sir, yes. ATNs and obstructive.
Second, what is the second commonest cause?
Sir, obstructive.
No, pre-renal.
Pre-renal.
They are all congestive cardiac failure.
Yes,
they are all living long. No?
Yes, sir.
So they have poor renal perfusion. Many of them have atherosclerotic renal arteries, which leads to a pre-renal state. And that is why they are more prone to NSAIDs and ARB, ACE inhibitor induced AKI. Right? So pre-renal is the second common, and third common is obstructive, post-renal. And in the renal, one of the causes is ATN. ATN. And among the glomerulonephritis? Membranous nephropathy. No, RPGN, the vasculitis is a common problem in the head. Yes. Right? So it is estimated that vasculitis is important. So that is where
Yes,
your
sir.
patient comes in.
Yes, sir.
No?
Yes, sir.
Okay. Now tell me,
Sir.
what formula will you use to calculate the EGFR in an elderly?
Sir, CKD API, MDRD.
देखो यार तुमने तो सारे बता दी MDRD. एक बताओ which you think is the most suitable.
Sir, CKD API.
CKD EPI इसमें भी कुछ varieties होती हैं CKD EPI की.
Sir, cystatin C होते हैं.
Cystatin C होता है और
Creatine.
creatine cystatin C भी होता है. Both together, right?
Yes, sir.
Have you heard of a Berlin Initiative study? No.
No.
There is a formula called BIS, Berlin Initiative Study, right? Will you look it up? That is
Yes,
believed
sir.
currently to be the most accurate for calculating EGFR in the elderly. Okay?
Yes, sir.
तो देखो यही चीजें आनी चाहिए, है ना?
Yes, sir.
ठीक है?
Yes, sir.
और AKI के कॉमन का और क्या कारण होते हैं AKI के? which you have if you have seen your working cardiology department.
Sir, cardiorenal syndromes.
So one is cardiorenal syndrome. What else?
Sir, the cardiorenal syndromes, hepatorenal syndromes.
Hepatorenal कहाँ यार elderly में chronic liver disease.
Sir, elderly. Sir, cardiorenal syndromes and medications are associated.
Procedure induced. You will often get a call that this patient underwent angioplasty yesterday and its creatinine, which was 1.2, has become 2.1 now. So what procedures? So contrast procedures.
Contrast induced nephropathy.
Whether they are CT heads, CT abdomen, CT chest for looking for cancers, whether they are angiographic studies for looking at the coronary arteries.
Sir.
So what other thing happens if you are doing endovascular procedure like
Sir,
stents and all?
atheromembolic.
Correct. So atheromembolic disease, right? So
Yes,
these
sir.
are, I'm just overviewing a 80-year-old man
Yes,
who
sir.
has acute kidney injury.
Yes.
So in a hospital setting, if you get a call, you will know these are the things I must look at.
Yes.
So pre-renal, in the renal ATN or glomerulonephritis, post-renal, then procedure-induced.
Yes, sir.
These people get admitted more frequently than a 30-year-old man. 80-year-old man is 10 times more likely to get admitted and investigated. No?
Yes. Yes, sir.
Okay. So much for your 80 years old. Now you go ahead and tell me the history.
Sir, in history
Dr.
of presenting it.
1 minute, hold on.
Sir,
Dr. Manu,
good evening, sir.
want to ask anything, please go ahead and ask in between.
Sir. Second,
Okay.
amongst cardiology patients, the
Yes.
use of Vimada
Yes,
Yes, sir.
correct.
very rampant.
Correct.
Yes, sir.
So it is another cause, and thereon sometimes they are given a combination of ACE-ARB.
Correct.
And in the presence of atherosclerotic renal vascular disease, giving ACE and ARB or either of the things
Yes.
can cause havoc.
Perfect. Correct.
Sir.
Okay.
Sir.
Go ahead.
Sir, in history of present illness, patient was apparently all right 6 months back when he noticed rash over his forearm, which was flat, red, and having in the indeterminate ages, flat initially, and has no bleeding, which evolved in the nodular lesions, and it healed by scab formation. This rash spares palm and appears both simultaneously on his flexure and extensor surfaces. For this rash, patient consulted some dermatologist at his native place and advised some topical ointment, which remember that told was a steroid. And after applying this application, that rash is promptly resolved, but it reappears on some another location.
Nilesh,
Patient
look, when you describe a thing, since your exam going, it should be in entirety. So the rash, you have to tell whether itchy, painful.
Sir, it's
देखो आपको बताना है ना उस टाइम,
yes, sir.
ठीक है?
Sir.
तो ये
Yes,
सब
sir.
उसी टाइम बताना है. When you are telling the rash, you have already gone to ointments and all. So पहले rash का description complete करो, है ना?
Yes, sir.
Palpable है, non palpable है,
Yes, sir.
itchy है, non itchy है, painful है, non
Sir,
painful है ना?
yes,
So how long does it take to heal?
sir.
If it heals, does it heal with a scar, or does it there is nothing left behind, right? Whether it comes in crops or one
Sir,
rash comes, then the other one comes. ये
sir,
सब पहले तो हमें बताओ. Then
sir,
you come to treatment.
sir, this rash is come in simultaneously and crops, sir. Sir, I already
Okay.
mentioned about that, and it
Yes.
does not discriminate between the flexor and extensor surface. It
Yes,
appears
that
on
you
both,
said.
simultaneously on both, and
Right.
it spares the palmar region. And
ठीक.
this rash is not associated with the fever, sore throat, and it does not have any discharge or any dilated vessels, any digital gangrenes. This rash does not have any associated with this not having any association with the sun exposure. This rash has no not having malar-like presentation, and
Itchy,
there
non-itchy,
is
painful, non-painful. ये
sir,
बताओ.
not sir, it is non-itching type of rash.
And painful, non-painful.
Sir, it does not having any painful. Initially, it was not any painful kind of rash. Sir.
Okay, go ahead.
And patient denies any complaint of tingling, numbness, and any complaint of pain in abdomen, bleeding per rectally, melena, hematomasis, or any complaint of shortness of breath or hemoptysis. And there is no complaint of nasal stuffiness or hearing loss. There is no.
Go ahead.
Sir, and there is no complaint of any red color or cola colored urine.
Okay, go ahead. Why do you stop?
Sir, and there is no complaint of any frothing or dysuria or any hello.
Yes, yes. We can hear you.
Yes, sir. Any complaint of dysuria, hematuria, any complaint of high colored urine, there is no complaint of frothing in urine. And with this rash only, he was initially presented to the dermatologist, and he advised to apply some topical ointment, which he removed the steroid. After application of steroid, this rash was promptly resolved, but reappears on another location, and these rashes appears and simultaneously in batches. So patient reassured and advised to continue the application of ointment, which he continued for 1 month. But as rashes continues to appear, he stopped applying ointment after 1 month.
Was there any history of alternative drug intake during this period?
No, sir. There is no history of any alternate medications. There is no history of any NSAIDs or any vaccines prior to this rash.
Okay, during the appearance of rash, was there any history suggestive of asthma?
No, sir. There is a past history. There was no as such history of asthma, or he does not remember he need to take any nebulizer or any inhaler.
Any history suggestive of CNS or peripheral nervous system involvement?
No, sir. There is no history of tingling, numbness. As I already mentioned, sir, there is no history of any tingling, numbness, or any seizure or altered behavior.
Okay.
Or loss of consciousness, sir.
Okay. So, what do you think this rash is?
Sir, it may be associated with some vasculitis, or it may be altogether another disease.
What disease are we talking about?
Sir, he was told by the dermatologist it was psoriasis, but as rash characteristics seen, it was not. That looks like psoriasis.
Okay. Okay. Go ahead.
Sir, with the before admission, about approximately 20 to 25 days, he done his routine investigation as he was doing. At that time, he remember his kidney function were normal, and he has normal urine examination reports. And with simultaneously, he consulted another dermatologist about 25 days back, and he was advised to take some oral medication of name he as a defloxicort, which he has to take 1 tablet per day, and he has to continue to apply the steroid. Advised to continue the steroid ointment.
Okay, go ahead.
Sir, he took the oral medication for 5 days, but he noticed that his rash, which was on lower limb, which increases in size and became more erythematous, and there was some tenderness, tenderness and increased local temperature. Patient denies any history of fever, chills, rigors, but he stopped taking steroid, oral steroid.
But this was at which place in the body? Lower limbs.
Sir, lower limbs.
Lower limbs.
Yes, sir.
Okay. Good.
So shall I continue?
Ah.
Sir, within a week, within week of stopping the steroid, he noticed that his urine output has decreased, which was he need to initial 5 to 6 times per day. Now it is decreased to 2 to 3 times, and urine output is also very low. And he noticed swelling over his feet, which was initially up to the ankle, and which gradually progresses. And at the time of admission, it was up to the knee. And and also patient complained of nausea, decreased appetite, and he had to get up at night with complaint of breathlessness, and he feel better while in sitting position, and he preferred to sleep while taking 2 to 3 pillows at night. Hello.
So carry on.
Sir, at this time also patient denies any complaint of fever. There is no frothing in urine, red color or cola colored urine, and there is no complaint of any dysuria, urgency, hesitancy, frequency, or straining while micturition. Patient did not have any complaint of chest pain, palpitation, or any complaint of loss of consciousness or altered sensorium. With this complaint, he consulted the nephrologist, and in view of raised creatinine level, he remembered that creatinine at that time was 1.9 milligram per deciliter. He was advised admission, which he was admit at the same day he was admitted, and on route evaluation, his BP was high, which need to start in over the his antihypertensive medication. He need to increase the doses, and antihypertensive tablets was increased from the initial two antihypertensive medications. His medications was increased to 3 antihypertensive medication with more dose and a type of antihypertensive medication. Patient creatinine continues to rise, and on day 4, his creatinine was 3 milligram per deciliter. So after doing coagulation, after doing investigation and coagulation profile, right kidney biopsy was performed on day 4. Sir, immediately post biopsy, patient complained of shortness of breath, and his saturation was fall to 60%. And BP was 90 mm of G systolic, and patient immediately shifted to ICU, and in view of persistent hypoxia, he was shifted. He was started on NIV ventilation. Recheck ultrasound was done, which suggested of perinephric collection, which was and patient for this received blood transfusion, and he was started on inotropic support in view of persistent hypotension. patient remains hemodynamically stable. So after 2 days of ICU admission, he was shifted to ward, but his urine output was persistently low, which was around 400 ml per day, and his creatinine was persistently increasing. So he was initiated on hemodialysis on day 7, and at the time of history taking, he was remain dialysis dependent.
Okay. Tell us now, a person who was having rashes for almost 6 months. Now he has developed reduced urine output, gradually rising creatinine, and there's an increase in the rashes in the lower limbs, which are tender and erythematous.
Yes, sir.
What does that imply? Where does the
Sir,
differential diagnosis take you? The history takes you into what will differential diagnosis?
Sir, rash rash became infectious.
Infective rash.
Yes, sir.
What sort of infection are we talking about?
The staph.
Staph. Okay, one. But staph
Another is
infection
strepto.
presenting as nodule, erythematous nodules is slightly difficult. It's more of scalding.
Sir, maybe after taking steroid, he has developed secondary infection in his rash.
Okay.
Oh,
What about other things? Could it be erythema nodosum?
Sir, erythema nodosum, sir, unlike.
Why?
quite unlikely. Nilesh,
Sir,
what is the classical rash of erythema nodosum?
sir, it is a tender on lower limb and it appears on the shin mostly.
Right, right. And so where is this rash?
Sir, it's a basic. It's a both upper and lower limbs.
No, you said classically lower limb. That's why we had gone into the erythema nodosum thing.
Yes.
So
correct.
can you tell us if it's erythema nodosum, what will different and erythema nodosum with reduced renal function? What diseases would you consider in these?
So,
Name diseases which present with erythema nodosum, rapidly deteriorating renal function, and
disease
people
का
end up in
नाम बताओ.
dialysis. Bolo.
Don't describe the same thing. Just tell us the name of the disease. Bolo, 1, 2, 3, 4. These are 4 diseases which I will consider if the patient has erythema nodosum and rapidly progressive renal failure.
sir, infection.
Which infection?
Streptococcal infections.
Streptococcal infection. Okay.
More common than that.
Autoimmune.
What
Okay.
autoimmune?
Sarcoid, sir.
Sarcoid. Very good. तो
And-
बड़ी मुश्किल से यार जवाब देता है.
And
और
other things which might present with erythema nodosum and renal dysfunction deterioration.
Sir, SL.
You said sarcoid. You said
sarcoid similar क्या होता है और?
SL is
चल ठीक है.
नहीं यार.
और
SL is jog.
any other granulomatous disease you know of?
Tuberculosis करता है.
Tuberculosis and fungal infection.
Okay. Can IgA nephropathy present with erythema nodosum and deteriorating renal function?
Sir, can
They
Yes,
can.
they can.
Yes, presentic IgA can have erythema nodosum.
Yes, sir.
And rash is going on for 6 months.
6 months.
So you know it can. देखो बात ये है ना, you can't dissociate this rash from the disease. So the disease probably started with the rash, and
Yes, sir.
gradually maybe there was a minimal involvement of the kidney initially, and now in the last 10 days, transformation has happened, and that is well described
Yes,
in
sir.
the IgA. Presentic transformation of the IgA.
Yes, sir.
है ना?
Sir, yes, sir. But sir, age is not
Yes.
Oh, देखो,
and he has a regular investigation was done for routine investigation such as urine and
But
kidney function.
was a skin biopsy done?
No, sir, not initially, and before the history taking kidney biopsy, skin biopsy was not done, sir.
Not done.
Okay. देखो मैं बताऊं नीलेश, I
Yes, sir.
always say this and I am repeating it. Diseases don't read books and come. Okay.
Yes, sir.
So they will not follow what is written. Haven't you seen myeloma at the age of 30?
No, sir.
You haven't seen, but I have seen. You know, you don't think कि myeloma होगा, but when you work up, you find that the chap has myeloma at 30 years of age, right? So it is not that that these can't happen, that IgA cannot happen in the elderly, right? Oh, ठीक है, biopsy may not have shown, but you can't say no. No, the vasculitis that you are considering, you can't link the rash to the vasculitis, no? Then, unless you say this is sarcoid.
Sir.
Nahi? What vasculitis in your mind will present with the rash going on for 6 months?
Sir, cryoglobulin and also for ANCA associated vasculitis.
Okay, chalo. ठीक है. So now, is this all in your history?
Sir, and on negative history, he denies any recent history of any drugs such as alternate medication, NSAIDs, or there is no history of recent vaccination or any
Right.
history of travel.
Okay.
So you finish your history?
History खत्म करो ना पूरी.
Sir, this is the present history of presenting illness, sir.
Go ahead. After that.
Sir, past history.
Yes.
Sir, shall I?
Yes, sir.
हाँ,
yes.
हाँ. Finish your history.
Wait, time
Say
is a
everything.
premium.
The patient is a known case of type 2 diabetes since last 10 years. He was taking oral anti-hypoglycemic agents for diabetes, and his sugars were fairly controlled, and he is doing regular checkup of sugars, kidney function test, and urine examination. And he is a known case of hypertension since last 5 years. He was taking telmisartan and chlorthalidone combination for their 1 tablet per day, and his BP he is checking at home, which was less than, around 130 by 90 mm of Hg. 2 years back, he underwent transurethral resection of prostate for in benign prostatic hypertrophy. After that, he don't have any complaint of urinary retention or lower urinary tract symptoms. Even 1 year back, he has a history of fall at home, and post fall, he was diagnosed as an intracranial hematoma. For that, he underwent craniotomy. After that, he took anti-epileptic medication for 6 months, and he don't have any complaint of seizure or any neurological deficit.
Okay. Then personal history, family history.
And he also denies any history of diabetic retinopathy, such as any previous surgery like laser photocoagulation or any intravitreal injections.
Okay.
In a family history, family history was non-significant. Personal history, he is a vegetarian by diet. He vegetarian by diet. He denies any history of addiction, or and he was complaining of altered bowel habitus, as a complaint of constipation since last 7 days.
That's it.
Yes,
अच्छा,
sir.
इस मैं बताऊं नीलेश, देखो डॉक्टर मन्नू आप भी बताना.
Sir.
No, I think if I were a candidate, I've stopped going for exams for now fairly long time, 5 years or so. I don't know what's the practice now, but I would have started by the history by saying that he's a known diabetic for last 10 years, known hypertensive for last 2 years, and has a rash for 6 months, and has this, right?
Yes, sir.
You know,
It gives a
Diabetes
background.
and hypertension are such a major cause of chronic kidney disease at this age. 80 years, hypertension is the biggest problem causing kidney disease because of atherosclerosis and hypertensive renal disease, right? Then you start thinking in whether he had a fairly compromised renal function, and something has happened in the last 2 weeks that has tilted the balance towards acute deterioration in the renal function as well, right? So if you had mentioned, of course, you can say the history of hypertension and diabetes, how well was the control, how was the diabetes, whether any complications of diabetes in your at the end of your history. You could have started your history from 10 days back or 6 months back, but you should have given this background that he's a known hypertensive, known diabetic. So Manu, aap kya keh rahe
Yes, sir. Yes, sir. It gives a background, and then you start the history with 6 months history of rash.
hain? Correct.
So the examiner has something in mind that he's already diabetic and hypertensive.
Yeah, I
And
never thought he was hypertensive or diabetic at all.
same here, sir. Same here, sir.
Right? So no, this changes the perspective in fair number of ways.
Yes.
Then we would have liked you to tell us whether there was any drugs that he was given just before the illness started. Any new, whether for his leg ulcers or the rash, he took an antibiotic or this thing. All this would have mattered. Whether he has AINS set in, right?
Yes, sir.
Right. So I think you should. These are major causes. Right.
Yes, sir.
A trauma history in 10 years back doesn't matter. Whether he fell down and had a neck femur fracture 20 years back, it is not relevant to this. Right. But
Yes.
these two diseases are the main culprit of renal failure, especially in the elderly. Right.
Yes.
The history has to be more crisp. Okay, Nilesh.
Yes, sir.
So,
Okay. So now tell us from your history what syndromic diagnosis and what disease that you have thought of, and then you tell us the examination.
Sir, I would like to take the syndromic diagnosis of rapidly progressive terminal nephritis.
Okay. You wouldn't like to keep a diagnosis of RPRF, but you are sure that this is glomerulonephritis.
Sir, possibility of acute nephritic syndrome is there, but there is no history of any
No.
immature.
You say
Hello?
yes or no. You say no.
Sir.
I won't.
Sir,
I am
Hello?
sure he's come because I am going to next question I am going to ask you is why do you think this is a glomerulonephritis?
Sir, there is a complaint of edema, hypertension, and oliguria.
Okay. So if somebody has an acute interstitial nephritis, how will that be different from this?
Sir, in acute interstitial nephritis, there is a hypertension and area is bit uncommon. Though it can present, but
Yes.
hypertension, accelerated hypertension kind of pictures, and with oliguria is present.
Okay. So okay, we agree to that. I agree.
yes,
Okay. Right. So you think this is RPGN and not
Yes, sir.
you would like to put it as RPGN and the cause of RPGN?
Sir, possibilities of ANCA-associated vasculitis with crescents and IRGN.
Why? No. RPGN को
And
छोड़
third
present
postulated
present
to
नहीं अभी बता सकते biopsy थोड़ी बता रहे हो तुम.
Sir?
You say this is
Sir,
RPGN.
IR infection related glomerulonephritis.
Okay, so you think this is, but then you said vasculitis.
Sir, first I will try to with rash going on.
Okay.
So I'll prepare
first-
possibility of small vessel. Sir,
First is small vessel vasculitis. Second is infection related.
infection related glomerulonephritis.
Post-infectious glomerulonephritis, PIGN.
Yes, sir.
Okay. So
Third-
why do you keep vasculitis as number one?
Sir, rash which typical occurring in the crops, which
Okay,
healing
one
and
rash.
going on
Please
in.
just go there. One is rash. We know the rash now by now. So one is
Sir.
rash. What else? Why number 1 vasculitis? Well, this is the commonest cause of RPG in
RPGN, elderly patients.
है ना?
He's
Yes,
80
sir.
years old.
80 years old, among the commonest causes of glomerulonephritis is a rapidly progressive
Rapidly
glomerulonephritis. What is
progressing.
the problem?
Yes, sir.
You should say this.
Yes. Yes, sir.
And with rash, that becomes vasculitis becomes even more common.
Yes, sir.
मतलब अपने
Yes.
diagnosis को आपको defend करना है.
Yes, sir.
Examiner is not going to, but you should be able to defend your diagnosis. जो भी बनाओ
Yes, sir.
गलत निकले कोई बात नहीं है.
Yes, sir.
You don't know the biopsy report in the
Yes, sir.
exam. It can come out anything. It may be AIN for
Yes,
all
sir.
I know. So that is not. But you have
Yes,
to
sir.
stand your ground. You have to say this is why I am making this. Okay.
Yes, sir.
What is the third diagnosis you kept? First is
Sir,
vasculitis, second
A-
is PIGN. Third,
Sir, age, it compare in keeping in mind age, I will try to keep as a paraproteinemia, cryoglobulin vasculitis.
okay. So that's the number 3.
Okay.
Right. Very good. I think we agree on
Yes,
that
sir.
part.
Yes,
Very
sir.
well done. Okay. Now examination, anything worth telling us?
Sir, except for rash, which is still there, though it is healed by scab formation, it is still there.
Okay. देखो एल्डरली में मैं बताऊं 2-3 चीजें जरूर देखना. एक, दोनों अपर लिम्स में, दोनों लोअर लिम्स में बीपी नापना. पल्सेस फटाफट पैल्पेट चारों करना. दोनों रेडियल, दोनों ब्रेकियल,
Pulse, sir,
डॉर्सालिस पीडियल. ये
sir,
जरूर
pulse,
देखो.
all pulses are present, sir. I'll
I'm
just
just saying, I know
positive.
what
Yes, sir.
I agree with you, but I'm just
Yes.
telling you
Yes, sir.
because you know an odd patient will have difference and he may be actually having atherosclerotic aorta or something.
Yes, sir.
80 years. Okay.
Yes, sir.
Okay. So there's nothing which adds and no anemia.
Sir, no, as he has already received some blood transfusion two PRCs.
At the
Oh,
onset, when he was admitted in the hospital, prior to the biopsy, how was the hemoglobin?
Sir, hemoglobin was 12 gram.
Okay.
रेटिना देख लेते हो तुम नीलेश?
Sir, देखता हूँ sir, but this patient, sir, examined by the ophthalmologist himself.
हाँ, what did they find?
Nothing, sir, normal.
Normal. Okay.
Yes, sir.
Right. So which vasculitis can cause, which renal diseases are associated with changes in the retina? Not vasculitis, renal diseases.
Sir, autoimmune diseases such as Sjogren's syndrome, which was associated with the dry eye, and uveitis, tubulointestinal.
Yes.
Then in rheumatoid arthritis, there is a
Vasculitis, why are you sticking to vasculitis? Which is the commonest disease you look at the retina and diagnose?
Sir?
Which is the commonest renal disease you look at the retina and say this is it?
Sir, diabetic kidney disease.
Yes. I asked what are the renal diseases which have changes in the retina, right?
So diabetic kidney disease.
You know, if you do this, the examiner will be sure somebody has told you that this is vasculitis, right? Listen to the question and
Yes,
answer. Okay.
Yes, sir. Yes, sir.
Okay. So retina, you think is you told us is normal.
No, sir.
Did you do the urine examination? And are you
Sir, yes,
expected
sir.
to do?
Yes, sir. Yes, sir.
Okay, what did it show?
Sir, urine examination, there is a RBCs are fulfilled and there is a proteinuria of 2+.
2+ and fulfilled RBCs.
Yes, sir.
Okay. What is the diagnostic thing in the urine of glomerulonephritis?
Sir, casts, RBC casts.
Right.
And
RBC
proteinuria.
Right. So RBC cast, WBC cast, proteinuria. Right?
Yes, sir.
What is the description classically for urine routine in a SLE patient?
Sir, urine routine in specially patient, there is a RBCs, dysmorphic RBCs, RBC cast, proteinuria.
Oh, what is it called? Is there a thing called telescopic urine or something? What is it called? Huh? कुछ होता है? नहीं. Okay. What are the type of casts you see in chronic kidney disease?
Broad waxy casts.
Very good. Okay. What are the casts you see in ATN?
Sir, in ATN there is a granular muddy brown.
Muddy brown cast. Very good. Right. Okay. ठीक है. मन्नू आप
Sir,
देखो.
so you feel that it's a case of vasculitis?
Sir.
Nilesh, can you hear me?
Yes.
Nilesh, can you hear me?
Yes, sir. Yes, sir.
Okay, so you say this is a case of vasculitis. It's RBRF, RPGN due to vasculitis in elderly.
Yes, sir.
So what are the possibilities you want to keep in vasculitis? Small vessel vasculitis. So if you, what do you expect in the kidney biopsy in this patient?
Sir, microscopic polyangiitis is my first possibility in small vessel vasculitis. Then this GP, granulomatosis polyangiitis.
Could it be EGPA also?
Sir, EGPA is a no, sir. Actually, there is a patient has a asthma, eosinophilia. All this. Though eosinophilia is a investigative findings, but asthma they have asthma and.
Okay. What is the difference in the age group of patients with MPO versus PR3 vasculitis?
Sir, PR3 vasculitis is between 50 to 60 years of age, 5th to 6th decade, and MPA is a 60 to 70, like 6-7 decade of life.
नहीं, इसको ना 10 साल और बढ़ा दो. 50 to 70 is anti-PR3. Okay. And the anti-MPO ANCA is usually 60 to 80 years old. It's usually 10 years more than the PR3 ANCA.
PR3, sir.
Okay. Suppose this patient would have presented with proptosis.
Sir.
So what kind of ANCA associated vasculitis would you have thought? Just plain simple, you look at the eyes and the patient has proptosis. Is it GPA?
Sir, GPA
or
granulomatosis is polyangiitis.
Okay.
Sir, PR3 ANCA. PR3 GP granulomatosis is polyangiitis.
GPA, na? Okay.
Yes, sir.
Suppose this patient simultaneously presents with features suggestive of peripheral neuropathy. So your diagnosis is going to sway towards what? Anti-MPO or anti-PR3?
Sir, with peripheral neuropathy, sir, diagnosis will shift towards the more towards the both have similar kind of peripheral neuropathy, but sir, microscopic polyangiitis.
No, it is more towards the granulomatous polyangiitis. Okay, GPA, sir. And it can be seen in EGPA also.
Sir.
Okay.
Yes, sir.
So, do you have the biopsy reports with you?
Sir, yes, sir.
Please read it out.
Sir, biopsy report, light microscopy, there is a section shows 11 glomeruli, out of 2 shows crescent, cellular crescent, 1 glomerular shows global glomerulosclerosis, and out of 11, 20 glomerulus appears enlarged hypercellular with proliferation of cells, intermingled prominent polymorphs. Interstitium shows edema and mild chronic inflammatory as cell infiltrates with intermingled eosinophils. Tubule shows presence of pus cells, RBC cast with few hyaline casts. Occasional tubule shows calcium oxalate crystals in the lumen. Interstitial vessels appears unremarkable. No evidence of vasculitis. There is diffused immunofluorescence. There is diffuse glomerular mesangial deposition of plus IgA 2+, IgG 1+, and IgM 1+. No excretion of C1q was seen. This biopsy is more. This biopsy conclusion is proliferative glomerulonephritis with.
Sorry, we missed.
I didn't hear
IG
you.
dominant IRGN.
What is the DI findings? I couldn't hear you.
Sir, IG dominant IRGN.
Okay.
IgA. Okay.
So
Right.
in such a case, the patient presents with oliguria, has ended up with dialysis. How would you
Sir?
like to approach this case? What are things you're going to do? Fast. 1, 2, 3, 4, 5, 6. क्या करोगे? And why?
Sir, first fluid and volume status. I will check fluid and volume status. I will make patient keep volume status
Dinesh,
keep
I'm
adequate.
asking
Then, sir, hypertension.
investigative. How are you going to investigate, approach this patient?
Sir, routine investigations, program with differential count, kidney function test, liver function test, urine routine with 24-hour urine protein or urine protein creatinine ratio, for ultrasound with PTPD INR for kidney biopsy, and ANA C3 C4 PR3 MPO ANCA.
Why ANA? Why do you want to do ANA in
Viral
this
markers.
patient? Why do you want to do ANA in this patient?
Sir, I'm general, sir.
Hey, it's going to cost patient. Na?
This patient, I am telling about general, but this patient, sir, we have done C3, C4, PR3, MPO, ANCA, HIV, HbSAg, anti-HCV, cryoglobulin level.
Achha, what is the
And
all these are negative?
anti-streptolysin O titer.
All these are negative?
Sir, C3, C4 were normal.
Right.
PR3, MPO, ANCA was normal. Viral markers were negative. Cryoglobulin level was normal. There is no cryoglobulin. Anti-streptolysin O was negative. Blood culture and urine cultures was negative.
All were negative.
Yes, sir.
Okay. So now, based on this, what is your diagnosis now, based on the biopsy?
Sir, on biopsy, syndromic diagnosis will send oxygen and with the IG dominant.
Could you switch off your microphone?
Sir, me, sir?
No, somebody else is
Would you switch
speaking.
off your microphone?
Somebody else is speaking. So we
Rashmi Das
can...
is speaking, sir.
Okay, okay. Okay, now go ahead. You tell us what is the diagnosis now, final diagnosis. You've seen the biopsy now, and how will you go about managing this patient?
Sir, syndromic diagnosis with RPGN with IgA dominant IRGN biopsy complication of hematoma in a known case of type 2 diabetic hypertension.
Okay, right. And now how will you, how do you propose to treat him? One you will give him dialysis as supportive treatment, and specific treatment, what would you like to do?
Sir, blood pressure control and antibiotics, sir, IV antibiotics for, and I will propose, sir, to do a skin biopsy also, which was, sir, already done for this patient.
Is it crescentic glomerulonephritis?
No, sir.
How do you define crescentic glomerulonephritis?
Sir?
What is the definition of crescentic glomerulonephritis?
Sir, in the crescentic glomerulonephritis, 50% of glomerula shows crescents.
Okay, more than 50%. Okay,
more than 50%. 50.
So this is RPGN, but an Ign nephropathy, underlying diabetes and hypertension, and now you have to tell us how will you manage him. Will you do something for his? Bhai, batao na, where this is where you come. Are you going to manage his kidney disease on RPGN or not? Or you are going to say because he is now on dialysis, you do nothing?
Sir, as IG dominant IgN, in antibiotic, specific antibiotic treatment and underlying condition comorbidities such as diabetes, sugar control is a mainstay of treatment, sir.
Okay.
No, his biopsy is not showing any chronicity, no? 1 out of 13 glomeruli. So you won't like
11. Yes, sir.
Would you like to immunosuppress this patient under the cover of antibiotics?
Sir, at that time, sir, no. If patients remain dialysis dependent, I will reach again to do a repeat biopsy. I will would like to do a repeat biopsy if it is still having
Nilesh, you have
see.
already caused a large hematoma in his kidney.
You want to do
Okay,
again?
you want to venture into this territory again? See, this is a classic presentation of a diabetic, elderly diabetic with some infection called
Sir.
having a IgA dominant infection related glomerulonephritis.
Yes, sir.
Okay, so why do you need? Is it recommended to do a repeat biopsy?
Sir, no, sir.
Okay, so how does a patient of IgN is treated?
Sir, infection, sir, underlying infection has to be treated, sir.
नहीं
Okay.
भाई ये वो PIGN थोड़ी है. This is IgA nephropathy. Are you saying this is PIGN?
No, no, sir.
Then why are you saying that? What is okay? What is the current treatment of IgA nephropathy? Which is
IgA.
presenting like RPGN, or there is
Sir,
no treatment?
steroid, methylprednisolone, pulse therapy, steroid, and cyclophosphamide.
Methylprednisolone plus cyclophosphamide.
Sir.
Okay. What trial is this?
Sir.
कौन से trial?
The crescent, I am telling you.
Pardon?
Sir, crescentic GN, I am telling you about, sir.
Crescentic GN थोड़ी है भाई, RPGN है. IgA who has presented as RPGN. Is that right?
Sir, IG dominant IRGN is.
Okay.
Okay, acha. You are trying to say that this is just IRGN and this
Sir.
is IgA dominant.
Yes, sir.
In a diabetic.
Okay.
Okay.
Right.
So you want to give antibiotics?
Yes, sir.
Okay. My question again is immunosuppression in this patient is a biopsy showing a lot of proliferation. The patient is dialysis
Yes, sir.
dependent.
Yes, sir.
Would you like to give immunosuppressant? If yes, why? If no, why? And if yes, which immunosuppressant would you like to give?
Sir, at this time, I'll continue with the antibiotics. If patients remain dialysis dependent, I'd like to try the immunosuppression with pulse methylprednisolone.
So how long are you going to wait for the patient to be on dialysis before you decide on giving immunosuppression to the patient?
Sir, books as such did not recommend for IgA dominant IRGN as a step for immunosuppression therapy.
Yeah, there is fair debate on that. I agree with you. Whether you should treat them or you shouldn't treat them.
Yes, sir.
Should you decide to treat him, you
Sir.
think steroids are a good option with diabetes, infection? Elderly, 80 years, he'll break his
So
neck.
I will prefer to treat with the IV antibiotics at presentation.
No, that of course we are agreeing that right now there is no immunosuppression because you think he has infection. Okay. Suppose your center decides that we will treat him with some immunosuppressive. What immunosuppressive you think after controlling infection, waiting for a couple of weeks? What immunosuppression you think would be ideal for this man?
Sir, I'll still go with the steroids, sir.
Steroid and cyclophosphamide? Eh?
Sir, no, sir, only steroid.
Only steroid. Okay. Right.
Sir.
Okay. क्यों मन्नू भाई आप क्या करोगे?
Sir, my take would be will balance the infection part first, and then if the patient does not become dialysis independent, will for another 2 weeks or so, then I'll give a trial of steroids, sir.
Right. Okay. So Dr. Manu agrees with you, and I think that's not a bad approach.
Sir.
Right.
But
so
again, sir, we'll have to be careful about the patient going into sepsis after giving steroids, sir.
Yeah.
So it's again, like you said, it's controversial, sir.
Correct.
Some people give steroids, some people do not. Acha, Nilesh, tell me, how would the C3 be in this patient? You said C3 was normal.
Why is C3 normal in him? Any reason?
Sir, in IgA dominant IRGN, it's a more 50 to 70% patient has a low C3 level, and
okay,
sir, it proposes that in IG staphylococcus endotoxins as a function as an antigen, as a super antigen on and directly binds to the antigen presenting cells, MHC class 2 on antigen presenting cells.
At this age, 80 years old, you have to balance, you just see the patient, we should not do any harm to the patient. So at 80 years of age, a patient who's diabetic, hypertensive, ending up with dialysis at such a rapid rate, immunosuppression, giving immunosuppression, you have to balance it out. You have to take care whether he's going to go into ESRD with the background of diabetes. So what is the thing you're going to look at before deciding on immunosuppression?
Sir,
you have to decide on immunosuppression. What is the most important finding or most important investigation you're going to target and then going to give immunosuppression?
Sir, I'll make sure that patient don't have any infection. I'll repeat the blood culture, procalcitonin levels. I can do the serum procalcitonin, and sugar in this diabetes patient, sugar has to be controlled. And if patient required, I will like to give IV insulin. Insulin, subcutaneous insulin, either rapid and long acting both.
Okay. And you look at the kidney biopsy. If the
Yes,
kidney
sir.
biopsy is not showing any chronicity, it's worth trying.
Correct.
So,
ठीक है, I think Dr. Manu has marked you and he will tell you your marks now.
sir, Nilesh, I'm too junior to sir, but my take would be your history has to be crisp, okay, and it has to be relevant. You don't have to, you describe that hematoma for quite a long period of time.
Yeah, it really didn't merit. I agree.
So it sways the examiner's attention, and it might be counterproductive. Okay,
Yes.
and my second take is once you're presenting a history, simultaneously do the negation. Negative history should be simultaneous along with every symptom.
Yes.
And if relevant symptom is coming time and again, so it's better to kill that symptom early on.
Yes.
Okay, you have presented well, you have answered very well, but it needs certain more practice. You have to soften down your history and make it more crisp.
Yes.
Correct. I
Sir,
think
sir is going to tell.
No, I think you've done well. I think there's no reason you shouldn't get 70% marks and you should pass without any problems. All I can say is all the best. Don't worry.
Thank you, sir.
You'll pass. Yeah. All Delhiites will pass, I am sure.
Sir, we wrap it up, sir?
Yeah, I think so. Okay. 7:30 हो गया मेरे ख्याल से.
Okay, 7:30 हो गए sir. हो गए sir, बिल्कुल.
Okay, right. Chalo,
Thank you,
bye
sir.
bye.
Thank you, sir.
Okay. Thank you.
Thank you.
Okay.
Thank you so much, faculty.
Manu, bye.
Thank you, sir.
Bye bye, Manu.
Sir, good evening, sir. Okay.